Dr. Allen. Thank you so much for joining us today to have a discussion around the manuscript Real-World Treatment Patterns and Outcomes in Patients with Primary Hemophagocytic Lymphohistiocytosis treated with Emapalumab. I'd love to take some time just to learn a little bit more about this important paper and study and share this with our community. But before we do, I'd love to introduce you to the community. So if you wouldn't mind sharing a little bit about yourself and what got you interested in histiocytosis. Dr. Chandrakasan, we'll start with you.
Thank you, Diana, for hosting this and having us here. I'm Chandrakasan. I'm associate professor at Children's Healthcare Atlanta. I lead the HLH program and the immune dysregulation program here, and have a long-standing interest in HLH research and clinical care.
Thanks so much, Deanna, for organizing this. We're really excited to share the results of this study, which is really incredible. It's a collaboration of over 30 institutions across the U.S. So we're excited to give you the outcomes of patients treated with Emapalumab. So I'm a pediatric hematologist oncologist at Texas Children's Hospital and Baylor College of Medicine. I co-direct our histiocytosis program with Dr. Ken McLean. I'm currently vice chair of research for the Department of Pediatrics. And I really developed an interest in HLH on my first night as a fellow when I encountered a patient in the ICU who had an acute critical illness. No one really understood it at the moment, and he tragically passed away within 24 hours. And I was just kind of struck by the severity of the disease and an opportunity to improve outcomes for patients in this space. And I think since then, HLH has really become a great sort of example of, it's a paradigm of uncontrolled inflammation. And I think broadly, the community is learning a lot about how to manage a range of patients by the example of HLH.
Well, thank you both so much for your passion and commitment to histiocytosis and HLH specifically. Before we jump into the manuscript and learning a little bit more about the background and key takeaways and findings, would you be able to explain a little bit more about what is HLH?
HLH means different things to different people, but the essence of it, we have an immune system that is extremely hyperinflamed. And because of extreme hyperinflammation of the immune system, it results in injury to your own body, and that results in multi-organ dysfunction. These are patients presenting with dropping counts, increasing coagulopathy, failing liver, seizures. Pretty much every organ system could be affected, and that could be shut down. If unrecognized and not treated appropriately, these conditions are usually fatal. In that sense, time is key. Interventions we offer to these patients are very critical. And as Carl mentioned, there's been a lot of paradigm shift based on research, and that has resulted in us innovating more and more better treatment for these patients. That's in that spectrum of things, I think this study plays out well in trying to understand how we can improve outcomes for this challenging disease.
Back in the old days, it was sort of like you applied what is HLH? Well, you know it when you see it, right? And that's not a very satisfying approach. And I think that's not how we should diagnose patients, especially when the only cure is transplant, and the only effective treatment for the kind of HLH that's inherited, or a major treatment, had been using high-dose steroids and a chemotherapy called etoposide that targets activated T cells. And the challenge for this is you're offering intense immune suppression and chemotherapy in a patient who's very sick. And so it seems very counterintuitive. And it led to a lot of, I think, clinical challenges where maybe patients weren't treated soon enough, or if they were treated for a long period of time, they developed toxicities from those therapies. Going back several decades, it's been known that this inflammatory molecule interferon gamma plays a central role in HLH. Mike Jordan from Cincinnati showed that with mouse models. And so what's exciting about Emapalumab is it's really a targeted therapy for kind of precision inflammation, or precision therapy for patients with inflammation, and that it specifically targets interferon gamma. And that's what differentiates HLH from sepsis or other hyperinflammatory conditions, although there are some other conditions that also express high levels of interferon gamma. And so the story that Dr. Sean's about to tell you is about what happens when you target interferon gamma in a group of patients with HLH.
Thank you. Yeah, I mean, and I know that this was an important discovery. Emapalumab has been very beneficial for a lot of families. What was the reason for conducting the REAL-HLH study? Maybe you can go into a little bit of background on the why to conduct it in the first place.
So, as Carl mentioned, of all the different inflammatory cytokine signals that come out when immune system is massively angry and activated, interferon gamma based on some urine studies, have been found to be extremely critical in controlling the inflammation and also end organ problems. So, based on pivotal murine data from Michael Jordan, that led to a pivotal study in 34 patients with primary HLH. Majority of them were relapse refractory patients. In that, there was overwhelming positive data that showed even in patients who get relapsed or refractory HLH, even with conventional treatment, use of emapalumab was shown to be beneficial, both for controlling the inflammation and also our ability to take these patients for definitive transplant that is potentially curative. Based on that data, FDA approved the use of emapalumab for primary HLH patients who either have a refractory disease or a relapse on conventional treatment or progressive disease, or there are patients who cannot tolerate conventional chemo, as Dr. Kalalan mentioned. Etoposide on a very sick child who's on oscillator on renal replacement is not a trivial thing to do. So there are patients who cannot tolerate conventional chemotherapy. So when this study came out, there was a lot of excitement, and followed by FDA approval. We really wanted to know, a few years passed by, how is this drug performing in a real world setting? Because in clinical trials, in order to assess the efficacy of a medication, we put in strict criteria. We want to make sure we are not getting extremely sick patients and end up losing the signal of a drug. So for that reasons, there are strict inclusion criteria, and we exclude a lot of patients from the studies. So, but in real world, now that it's FDA approved, we wanted to see in a real world clinical situation how physicians are using this medicine, and if they're using it, how, in what combination they are using it, and when during the disease course they're using it, and what is the overall outcome, and most importantly, how many of them you're able to take them to transplant and have a long-term cure. So I think that information was unknown, and that's a critical part of information that many physicians and treating physicians and families were asking. So this study that we'll be discussing later is a step towards answering that question.
Well, it's very exciting, first and foremost, that it was FDA approved. And then I very much appreciate on behalf of the community that you wanted to see how this worked in the real world to be able to further understand the benefits of emapalumab. So how was the REAL-HLH study done? What was that process like?
It's a simple conceptual model. Actually doing it's not quite so simple, but basically we solicited institutions that had treated patients with emapalumab to collaborate on this project. There was specific case report forms, so everyone collected their data in a systematic way. Remembering that these patients were not treated as part of a clinical trial, but they were treated according to physician discretion. We still established rules about who could be considered for this study. And so for the patients we're going to talk about, they had to have received emapalumab during the time period that Sean will talk about in a second, as a 2-3 year time period. And then they had to have a diagnosis of familial HLH. So that means they're presumed to have inherited defects in cytotoxic NK cell, that natural killer cell or T cell function that we typically attribute to inherited risk of developing HLH. And if they met that criteria, they were considered to have familial HLH. So I should say we didn't require them to have proven gene defects. Rather, they had to not have HLH known to be caused by autoimmune disease or cancer for this cohort.
I think based on this broad thought that we want to capture as many patients who have gotten emapalumab, so we took a 3-year window between approval of emapalumab by FDA, that is in November 2018, to October 2021. We surveyed institutions to see how many have used emapalumab, even one dose for a patient, and we noticed and how many of them are willing to participate in the study. So based on that, we were able to identify 33 institutions who have used emapalumab, and of that, 46 patients where the emapalumab was used for primary HLH. So this is the determination of whether this is primary or not, as Carl mentioned. It's not always black and white with gene defects, but if you're able to, based on a team of experts who looked at these patients, made a determination this is primary HLH. And based on those criteria, we were able to identify, of the total 105 patients who got emapalumab that were enrolled in this study, 46 of them were noted to have primary HLH. And that's a big number considering primary HLH is still a rare diagnosis. And the pivotal study had 34 patients. Having 46 patients is still a good number for us to be able to make some meaningful conclusions.
And I imagine that you were looking to understand the patterns of behavior for the patients on treatment and then the outcomes. So what were some of the things that the REAL-HLH study was aiming to find out?
So broadly, we were looking at the experience of patients who received Emapalumab in terms of efficacy, and then what were the outcomes of the patients in terms of response of inflammatory biomarkers. Were they able to make it to transplant, and what was survival for that group? Additionally, we also analyzed the patient cohort. What were they like? Were they a representative group from what we consider for familial HLH? And then if you get into the weeds in the paper, we also analyze, what are some differences in outcomes for patients who were first treated in the ICU versus treated in clinic or on the inpatient floor. And we're starting to look at some of these data to understand, do we want to use Emapalumab early, and what kind of outcomes can we expect by using this drug? So it's a descriptive study of this, national, really, I would say, pretty market penetrant in terms of the entire United States, representative at big hospitals, small hospitals, for this cohort of patients treated in the, just as Emapalumab's becoming available, how did they do? And then also, like Sean said, how does it compare to the study? Is the study really representative, or, were there aspects of patient selection, having a small number of patients that you can have some variability, et cetera, and say how well do these cohorts match?
This basically is the title of the paper, and real-world treatment patterns and outcome of patients with primary HLH treated with Emapalumab. It's published in a very reputed journal, Blood Advances. That's an official journal of American Society of Hematology. It's published this year, so it's available online. The more details for this publication could be found there. The slide 2 basically goes over the bigger schema of this study. We previously discussed it's 33 sites, and the study period between November 2018 to October 2021. And during that period, any patient who had gotten more than one dose of Emapalumab were enrolled in the study. And the data abstraction through a standard case report form has been processed. And after that, then we had several, as Carl mentioned, we are looking at the patient profiles. What are the type of patients who have been getting Emapalumab? Looking at the treatment patterns, what are the dose they're starting with, and what is the response to the inflammatory parameters, laboratory parameters of inflammation, and ultimately what are their long-term outcomes, both with transplant and some who are not gotten transplant but still long-term survival. And the deck basically shows, initially when we got the data back, we had put together a team of experts to look at the data to make sure we look at it in an unbiased way to see what subset of these patients are truly primary HLH. We went by some defined criteria to make sure either we have a gene diagnosis, or there is family history, or the age of presentation is such that there is highly likely to be primary diagnosis of primary HLH. And the other, as Carl mentioned, some of them are, we want to make sure they are not underlying rheumatological disease or autoimmune disease process, cancer, or infection itself is the only source of driving HLH. So when we did this, ultimately of the bigger cohort, we were able to identify 46 of these patients had primary HLH, and the purpose of this discussion is focused on this 46 patients that were published in this paper. There is another follow-up discussion and publication on the secondary HLH part. So for this discussion, we'll focus on the primary HLH with 46 patient data. And looking at the characteristics of this patient, as we discussed, the label, FDA label, is for refractory and relapsed patients with primary HLH. What we noticed is in the real world too, majority of these patients who ended up needing Emapalumab were either refractory or relapsed patients or progressing on conventional therapy. So in that sense, when Emapalumab was used in primary HLH, these were for indications that the FDA had approved it for. And the median starting dose, that's the dose where physician starts them, was 1.1 milligram per kg. That is also in line with what is published in the pivotal study. But as we discuss later, the outcome patterns, when you look at starting dose influence outcome, we did notice that patients who have gotten a little bit higher dose to start with, like at 3 milligram per kg, had a slightly better outcome, even though it's not statistically significant. But we did find a trend towards statistical significance, suggesting there might be a patient's getting 3 milligram per kg. Maybe in a larger cohort, if you analyze the data, maybe there is an advantage. So the starting dose, as discussed, the median was 1 per kg, and the duration on a median 71 days was the duration of treatment. As we discussed, most patients with primary HLH eventually progress on to go to transplant. So in that sense, 2+ months is about the time many would also need to progress to good control and also to eventual stem cell transplant. One of the big goals, in addition to knowing who are the patients who are ending up receiving emapalumab, as we discussed earlier, these are patients still who are refractory, difficult to treat disease, progressing on treatment. We wanted to really see, adding this drug, does it make a difference to the underlying inflammation? We discussed HLH being such an hyperinflamed situation. So several lab parameters that go with inflammation look very abnormal in these patients. And we looked at a bunch of different inflammatory markers and end organ dysfunction markers to see how are we faring with the addition of this drug. When we looked at how physicians are using emapalumab, what we noticed is it's not, majority of them are used in combination with other standard treatments. Majority of them have gotten steroids. Majority of them had received etoposide by the time they are receiving emapalumab. But despite that, they are having a refractory course prior to starting emapalumab. So, but when we initiated emapalumab, what we noticed is there are several parameters: ferritin, fibrinogen level, soluble IL-2R, CXCL9. These are several inflammatory markers and biomarkers that tell, are we doing a good job at controlling inflammation? What we noticed is majority of them, with the addition of emapalumab to the current regime or whatever additional treatment that physician initiated, showed improvement in several of the parameters. Their blood counts have gotten better. Their fibrinogen levels, that is a correlate of how much bleeding tendency a patient has, and the inflammatory markers like CXCL9, ferritin, and soluble IL-2R in majority of the patients significantly improved or normalized. So that was extremely reassuring for us, and to see this happen in real world, in addition to seeing that happen in a pivotal study, seeing it happen in a real world gave us a lot of reassurance that the drug has this definite signal in terms of improving inflammatory markers in these patients. We talked about in primary HLH, because they have a presumed or a known genetic defect in underlying T cells and NK cells inability to control infections or regulate inflammation. In majority of the patients would eventually need a stem cell transplant to be able to have a definitive cure. The emapalumab is, in these situations, is used as a bridge to transplant, so that we get them to transplant in a much better health, less inflammation. So all these are critical, because we know lesser the inflammation, better the treatment outcome. So for us, one of the important goals for the study is to see, despite these patients having a refractory relapsed disease, are we able to get more patients to transplant, and are we able to cure more patients with definitive stem cell transplant procedure? So those two were other important parameters that we wanted to study. So when we looked at it, we were of the 46 patients, the physicians, there are several parameters we look at to eventually say who are eligible for stem cell transplant. What we noticed is majority were still able to proceed to stem cell transplant. That's a big thing, because there is a significant proportion of the patients, when they get a relapsed refractory disease, unfortunately, they succumb to HLH even before proceeding to transplant. So to see majority of our patients on emapalumab containing regime is able to proceed to transplant was reassuring. And even among the patients who proceeded to transplant, more than 70% of them are survivors post stem cell transplant at 1 year post transplant. All this on a whole, looking at a relapsed refractory cohort who got this emapalumab containing regime, majority are able to proceed to transplant. Of the patients who proceeded to transplant, majority of them had a good outcome. That to us was very reassuring. I would like to have calls take on. That for me was striking, because what I do is both immune dysregulation, HLH care, and also stem cell transplant. Many of these patients, transplanting HLH is not a walk in park. Its transplants are in general very involved, has a lot of toxins involved. HLH brings an additional level of complexity and challenges because the amount of inflammation they come in with. For us to be able to take these patients with relatively well controlled inflammation, there might be a signal of maybe the transplant outcomes are also better. And this study gives us some preliminary data to work on to look at these things in much more detail later.
Yeah, Sean, I think of kind of three critical time periods in managing patients with HLH. One is sort of the acute inflammation around the time of diagnosis, right? And I think that the previous slide showed that there was a correction of a lot of the inflammatory markers that I think signals that there's an association between getting this drug and having an improvement in inflammatory biomarkers in a lot of the patients. But then trying to keep the patient quiet, as we say, while they make it to transplant. Sometimes it takes 3 or 4 months to find the right donor to get to transplant. If we're relying just on chemotherapy, we really have an increased risk of infections and things like that because of the bone marrow toxicity. Having a targeted agent, at least in these patients, it showed that many patients were able to make it to transplant with this approach. Again, some of these patients did have other therapies at the same time, but at least in this cohort, there was a signal of what we would, at least I would say, what is a group of patients who were able to make it safely to transplant without additional safety concerns from the drug. And then I think in a second here, you can show the actual transplant outcomes. So that's sort of the third period so it's the acute inflammation, bridging to transplant, and then what happens to patients once they're transplanted. On this last slide, we show here the overall survival from the patient cohort. It's difficult to directly compare patient groups that were evaluated with different methods, different time periods, et cetera. But I think we can say overall, this curve, which shows basically it's the probability of survival over time, right, which shows approximately 75% overall survival is, I would say, historically favorable for a group of patients with familial HLH. Sean, would you agree with that?
Yes, I think what is even more important takeaway is this is not all primary HLH. This is already a group of cohort that is enriched in relapse refractory or progressive disease. So to have a 70% overall outcome is, I think, when compared to historical control data we have, I think I would say it's data that points towards a progressive improvement in outcome.
And it's very similar to the pivotal trial too, I think, which is reassuring. Yeah, so I think this is kind of a first look at the data. I think it shows the power of massive collaboration among multiple institutions looking at real world data. We're still able to learn a lot from patients, even if they're not initially treated on trial. And so I think we also just want to acknowledge the contributions of all of our co-investigators at each of those sites, and for the patients and families for agreeing to participate. And also, the study was done in partnership with Sobi, who helped us to organize the study. I will say too, this is just the beginning. We were showing you half of the patients that we have data on, so data on the other half are forthcoming. So, some of which have been published actually, I think, just this last couple of weeks for patients who had rheumatology-associated HLH. And then we have in the works some more details on the bone marrow transplant outcomes.
Well, this is very striking and very promising. It's just with something as progressive, aggressive, and rare like HLH, to have an opportunity to see real-world experience with this therapy really supporting patients through to transplant is very encouraging. And so we hope that this reaches more families and more providers as well, who can learn more about it and see whether or not Emapalumab would be beneficial for their patients or for their families. It sounds like this was the first step to learning how Emapalumab is used in routine clinical practice and the effectiveness in patients with HLH. and then that there's opportunity to learn even more now, and that people will be able to maybe participate in future studies as they come up, which will be keen to learn from you and your colleagues as you progress in the learning process. If there are opportunities for people to get involved, that maybe we can share something at the start of a study and help to increase that opportunity. Because I know that these types of studies sometimes are really important for families to getting the proper care that they need for those really amazing outcomes that you shared. Is there anything else that you'd like to talk about related to this study, or any particular message you'd like to share with the Histio community who's listening in?
I would just say, thanks, Deanna, to you and the History Association for your interest. And this was billed as a 7-minute podcast, and we have now 35 minutes. So we get excitable when we talk about HLH. So thanks for accommodating that. We do have this data set. I think, we can't collect new data on patients, but if there's specific questions that people have, we can certainly reanalyze the data if there's some ideas that colleagues have, or if we want to compare the data to other data sets from other countries or other investigations. But also, I think just as we discuss this at meetings, upcoming meetings, and just informally, how can we work together to make the fastest improvements in outcomes for patients with HLH is our shared goal. So Shannon and I are always happy to talk about that in whatever context possible.
Wonderful. Well, thank you. Appreciate you taking the time to share all of this with us. And the slides are really helpful visuals to see exactly what you were seeing as you were analyzing the findings. So thank you for all that, and thank you for your passion and your heart for the HLH community and the Histio community as well.